Hello guys, my today's lesson is about one of common childhood solid tumors, that is about rhabdomyosarcoma. When we see the epidemiology of rhabdomyosarcoma, the annual incidence of soft tissue sarcoma is 8.4 cases per 1 million children younger than 14 years of age, and rhabdomyosarcoma accounts for more than 50% of soft tissue sarcomas, and it accounts for approximately 3.5% of childhood cancer. The tumors may occur at virtually any anatomic site, but they are usually found in the head and the neck, orbit, and the genitourinary tract, extremity, and other places. But the most common site, head and the neck, and the genitourinary tract. This is followed by extremities. Retroperitoneal and the other sites account for the remainder of the primary sites. The incidence at each anatomic site is related to both patient age and the tumor type. Extremity lesions are more likely to occur in older children and to have alveolar histology. Rhabdomyosarcoma occurs with increased frequency in patients with neurofibromatosis and other family cancer predisposing syndromes such as Leo-Framini syndrome. When we see the pathogenesis, rhabdomyosarcoma is thought to arise from the same embryonic mesenchyme as striated skeletal muscle, although a large percentage of these tumors arise in areas lacking skeletal muscle such as bladder, prostate, and vagina. On the basis of light microscopic appearance, rhabdomyosarcoma belongs to the general category of small round cell tumors, which includes Ewing sarcoma, neuroblastoma, and Hodgkin's lymphoma. Definitive diagnosis of a pathologic specimen requires immunohistochemical studies using antibodies to skeletal muscle, such as desmin, muscle-specific actin, and myogenin. There are three recognized histologic subtypes. The first one and the most common one is the embryonal type, which accounts for approximately 60% of all cases, and it has an intermediate prognosis. The Butterworth type is a variant of embryonal form in which tumor cells and edematous project into a body cavity like a bunch of grapes, and it's found most often in the vagina, uterus, bladder, nasopharynx, and the middle. The alveolar type accounts for approximately 25 to 40% of cases, and it's often characterized by the presence of translocation FOX1 fusion transcript. The tumor cells tend to grow in the nests that often have a cleft-like spaces resembling alveolus. Alveolar tumors occur most often in the trunk and extremities, and they carry the poorest prognosis. The third one is the pleomorphic type or adult form, and this one is rare in childhood, accounting for less than 1% of cases. When we see the clinical manifestation of rhabdomyosarcoma, the most common presenting features of rhabdomyosarcoma is a mass that might or might not be painful. Symptoms are caused by displacement or obstruction of the normal structures. For example, origin in the nasopharynx might be associated with nasal congestion, mouth breathing, epistaxis, and a difficulty with swallowing and chewing. Regional extension into the cranium can produce cranial nerve palsy, blindness, and the signs of increased intracranial pressure with headache and vomiting. When the tumor develops in the face or cheek, there might be swelling, pain, trismus, and extension occurs, and also paralysis of the cranial nerves might happen. Tumors in the neck can produce progressive swelling with neurologic symptoms after regional extension. And orbital primary tumors, which are responsible for around 9%, are usually diagnosed early in their course because of the associated proptosis, preorbital edema, ptosis, change in visual acuity, and the local pain. When the tumor arises in the middle ear, the most common early symptoms are pain, hearing loss, chronic otorrhea, or mass in the ear canal, and the extension of the tumor produces cranial nerve palsy and the signs of intracranial mass on the involved side. An unremitting croupy cough and a progressive stridor can occupy rhabdomyosarcoma of the larynx. Rhabdomyosarcoma of the trunk or extremities often is first noticed after trauma and initially might be regarded as a hematoma. And if the swelling does not resolve or increase, malignancy should be suspected. Involvement of the genitourinary tract can produce hematuria, obstruction of the lower urinary tract, recurrent UTI, incontinence, or mass detectable on abdominal or rectal examination. Paratesticular tumor usually manifests as painless, rapidly growing mass in the scrotum. Whereas vaginal rhabdomyosarcoma might manifest as a grape-like mass of tumor tissue bulging through the orifice, known as sarcoma outroides, and it can cause urinary tract or large bowel symptoms. Vaginal bleeding or obstruction of the urethra or rectum might appear, and tumors in any location might disseminate early and cause symptoms of pain or respiratory distress associated with pulmonary metastasis. Extensive bone involvement can produce symptomatic hypercalcemia, and in such cases, it might be difficult to identify the primary lesion. When we see the diagnosis of rhabdomyosarcoma, early diagnosis of rhabdomyosarcoma requires high index of suspicion, and the microscopic appearance is that of small round blue cell tumors. Neuroblastoma, lymphoma, Ewing sarcoma also are small round blue cell tumors from which suspected myosarcoma must be differentiated. The differential diagnosis depends on the site of presentation, and definitive diagnosis established by biopsy, macroscopic appearance, and the results of immunohistochemical staining and analysis of PAX and FOX1 expression 1. A lesion in an extremity might be thought to be hematoma or hemangioma. An orbital lesion resulting in proptosis may be treated as orbital cellulitis or bladder obstructive symptoms, and it might be missed. Adolescents might ignore or embrace to mention paratesticular lesions for a long time. CT or MRI is necessary for the evaluation of the primary tumor site. With signs and the symptoms in the head and the neck area, radiographs should be examined for evidence of tumor mass and for indication of bone erosion. MRI should be performed to identify intracranial extension or meningeal involvement, and also to reveal bony involvement or erosion of the base of the skull. For abdominal and pelvic tumors, CT with contrast agent or MRI can help delineate the tumor. A radionuclide bone scan, chest CT, bilateral bone marrow aspiration, and the biopsy should be performed to evaluate the patient for the presence of metastatic disease and to plan treatment. When we see the treatment is multidisciplinary, and it includes the pediatric oncologist, pediatric surgeon, or other surgical subspecialties, and most often the radiation oncologist. Unfortunately, most rhabdomyosarcomas are not completely resectable at initial diagnosis, and treatment is based on the risk classification of the tumor, which is determined by the stage of the tumor histology and the fusion status, and also the amount of tumor that was surgically resected before chemotherapy. Stages depend on primary sites, favorable versus unfavorable, and the tumor invasiveness, T1 or T2, lymph node status, tumor size, and the presence of metastasis. Favorable sites include female genitalia, paratesticular, and head and the neck, or non-parameningeal regions, and all other sites are considered unfavorable. Regarding prognosis, prognostic factors include age, stage, histology, primary site, and among patients with resectable tumor and favorable histology, 80 to 90% have prolonged disease-free survival. A resectable tumor localized to certain favorable sites, such as the orbit, also has high likelihood of cure. Approximately 65 to 70% of patients with uncompletely resected tumor also achieve long-term disease-free survival. Patients with disseminated disease have a poor prognosis. Only approximately 50% achieve remission, and fewer than 50 of these are cured. Older children have a poorer prognosis than younger children. This is what I have about rhabdomyosarcoma. Thank you for listening.